Associated disorders, its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendation nor opinion made by any member or physician, nor do we advocate any treatment. You are responsible for your own medical decisions. Now I'm going to turn over the introductions of our speaker to Martha Butterfield, the Program Coordinator of NJCTS. Marty?
Kelly, thanks, and good evening everyone and welcome. Before I begin the introduction of tonight's presenter, I would like to call your attention to the slide on the screen about our annual family retreat, Camp Bernie 2013. Registration is closing this Friday, May 10th. Space is limited, but we have a few more openings still available. So if you're interested in attending, don't delay. Electronic registration is available on our website. Camp Bernie has been described by one of our families as one of the best weekends of the year. For families living with TS, it's a great opportunity for kids to make friends and for parents to connect with other families. Now to the introduction of tonight's presenter, Dr. Mark Mintz. Dr. Mintz received his MD from the University of Medicine and Dentistry, Robert Wood Johnson Medical School in New Jersey, and completed his pediatric residency at the Albert Einstein College of Medicine, Montefiore Medical Center in New York. He is triple board certified in child neurology, pediatrics, and neurodevelopmental disabilities. He's widely published and has been an invited lecturer at a number of national and international conferences. Dr. Mintz is the principal investigator on a variety of clinical drug trials, has been the protocol neurologist for a number of national pediatric AIDS clinical trials, and has participated in an array of committees and task force of the National Institutes of Health and the New Jersey Governor's Office. Additionally, Dr. Mintz has served in the National Health Services Corps of the United States Public Health Service and has volunteered for medical relief missions in Romania and Russia. Dr. Mintz, we are delighted to have you join our webinar family, and without further introduction, I'm happy to turn tonight's presentation over to you.
Thank you very much. I appreciate that. And of course, again, we said tonight's topic is medication management for tics and Tourette syndrome. Before starting, this is a list of disclosures for the past year. All of these work that I performed listed here has been through the Center for Neurological and Neurodevelopmental Health, as well as the Clinical Research Center of New Jersey, for which I am President and CEO, and also founder. So, as many of you know, Tourette syndrome, and tics for that matter, have a long history. This is a little bit of a run-through of some of the background of that. Way back in 1498 are some of the initial descriptions of motor and vocal tics in a priest, and of course, in those days, a lot of that was considered demonic possession rather than a biological condition, as we now know. It wasn't until 1825 that it started to come around to be more understood as a distinct medical disorder described with involuntary movements and the classic coprolalia, which is the involuntary uttering of inappropriate words, often associated with Tourette syndrome, but as many of you know, that tends to be only affect a minority of individuals who are afflicted with Tourette syndrome and tics, but that's what's been popularized. In 1884, there was the first actual case consistent with Tourette syndrome, but by Hewlings Jackson, but not named after him, because in the following year, Georges Albert Edouard Brutus Jules de la Tourette came on board and described a series of individuals with what we now know as, named after him, as Tourette syndrome. He described a childhood onset disorder where there were stereotypes, which means movements that could be sort of somewhat predictable, and vocalizations, which have been now labeled as a tic movement, type of movement disorder. The coprolalia that I mentioned, echolalia, which is repeating what others say. These symptoms would tend to wax and wane over time. And even back then, they noted this concept of premonitory sensations, which is very classic for tics of many types. And as many of you know, it's somewhat akin or analogous to an itch, this feeling of something that you must take care of, if you will, to receive some relief. So it's sort of that itch that you have to scratch, and that's sort of the premonitory symptom. And then the scratching would be the actual tic, which then relieves you of that premonitory feeling. And they also noted that this tended to run in families. So there's a certain aspect of heritability, although at that time there wasn't much known about genetics. And then it wasn't until the early parts of the 20th century that the approach to Tourette's was initially one more of a psychiatric disorder or psychological disturbance. And so there was this push towards more psychosocial and psychoanalytic treatments. But in 1968, they stumbled across the concept of pharmacological therapies for tics and Tourette. This progressed shortly thereafter with some surgical interventions that are not recommended at this point. We've progressed now to, as you see in 2006, some newer approaches with deep brain stimulation. In 1972, the establishment of the Tourette Syndrome Association, so there now is more of a grassroots approach to the disorder. The recognition that behavioral therapies can work, habit reversal therapy in 1974, now evolving in 2010 to a more comprehensive behavioral intervention for tics that involves habit reversal as well as cognitive behavioral approaches. In 1984 was the first Food and Drug Administration, or FDA, approval for a drug directly approved for treatment of tics. That's Pimozide or Orap. And in all this time, since 1984, there's been only one other drug that's been approved specifically for tics. So despite a disorder that we've known since the 1400s, we haven't come too far, but there have been some major advancements lately in understanding of gene and brain changes in Tourette's, really dispelling any remnants that Tourette's is not a neurobiological disorder. It's truly a neurobiological disorder, even though it's still classified as a mental disorder of mental health, which we'll talk about in a moment. And as we learn more and more, treatments, I think, will improve as we understand the pathophysiology or the underlying causes of tics and Tourette syndrome from a biological perspective. So Tourette syndrome can affect up to 1% of children. And of course, many of these children grow up to be adults and have residual problems with Tourette syndrome. So there are many adults that also are afflicted by tic disorders. Tourette syndrome encompasses tics, and we'll look at the diagnosis in a moment, but there are other disorders that involve tics that don't reach the threshold of a Tourette diagnosis. As I mentioned, this is a neurobiological disorder. There are different circuits in the brain that control movements, and for different reasons in these circuits in people with tic problems and or Tourette disorder or syndrome. Mostly due in some part to neurochemical changes involving these chemicals, or what are called neurotransmitters, which we'll talk about in more depth in a moment, dopamine, serotonin, noradrenaline, and other neuropeptides. There might be, and some people might conceptualize it as an imbalance, or there might be other factors involved, and it's somewhat more complex than just a typical or simple chemical imbalance that can be corrected, but to some degree that's one way to conceptualize it. And it disrupts these movement pathways or movement circuits and causes an involuntary movement problem manifesting with tics and other problems. As a neurobiological disorder, there appears to be a genetic susceptibility to it. So in some individuals, it can be traced back to problems within the genes. Now, when you have a genetic susceptibility, in some cases, as you can see from the cartoon, that can be something that runs in families, but there are many genetic disorders where the person with the problem is, if you will, the first one with that genetic problem due to a mutation or a change in their DNA. So it's not always something that you will see running in families, but often it will be running in families. And there are also acquired forms of tic problems, movement disorders, and Tourette syndrome. In other words, from something that happens either during fetal life or after birth, not necessarily something that's inborn within your genes. And that could be from infection or inflammation or other issues. And we'll talk about some of those mimickers. So as I mentioned, the evolution of the diagnosis of Tourette syndrome was first captured under a psychiatric diagnosis. Historically, that's the way it evolved. With the advent of the Psychiatric Mental Health Diagnosis Manual, or what's called the DSM, or Diagnostic and Statistical Manual, of different versions. We're now on version 4, and version 5 will be coming out soon. There are different tic disorders listed within that manual. The practical aspect of that is that then there's a stigmatization that Tourette disorder was a mental health disorder, and as I mentioned, it's truly a neurobiological or neurological disorder. It does have a lot of associated psychiatric problems and mood problems that we'll discuss, but it needs to be thought of as a biological disorder and should not be, if you will, sort of stigmatized as someone who's has some control over the disorder, that it's just a behavioral issue or a result of someone's upbringing or some other environmental changes. But truly, it's within the brain. It's a brain disorder. And with many, if not most, of the diagnoses that are listed within the mental health manual, the DSM manual, there is an understanding now that most of them are or do have neurobiological basis to their problems. Now, there's a practical aspect, as I was mentioning, that when it comes to issues such as health insurance coverage, there's been some issues about splitting mental health from, if you will, medical disorders. Neurological disorders are medical disorders, so Tourette syndrome really should be considered more of a medical disorder, and mental health insurance coverage might not be as robust as medical coverage. They might not cover various things. They might limit their coverage. There's been some push from a government side to create parity between mental health diagnoses and medical diagnoses, but in practical terms, it's still a problem. So my feeling is that, and the way I actually diagnose these individuals is something that's more medical first, and secondarily, if you will, Tourette syndrome. So it's a movement disorder, an organic brain disorder first, and then secondarily, the various associated psychological problems and neuropsychiatric problems. So you could have a Tourette disorder, chronic motor or vocal tic disorder, transient tic disorder, and tic disorder not otherwise specified, and more or less the treatments are that we'll talk about tonight can be applicable to any of these 4 diagnostic categories. Now, for the diagnosis of Tourette syndrome, it requires multiple complex motor and at least one vocal tic, and we'll talk about that in a moment. The onset should be prior to 18 years of age, and the symptoms should be present for at least 1 year from the onset. You could have some symptom-free intervals. Of course, the symptoms do wax and wane. That's part of the disorder. But it shouldn't be longer than 3 months that the symptoms are gone. And the disorder can't be the result, or the presentation, I should say, should not be the result of anything else like side effect of medications or some other illness. It should be somewhat unique. So what we have here in terms of DSM-4 diagnoses or mental health diagnoses, these are disorders whose definition of the diagnosis is not dependent upon the biological cause. And the issue with all these diagnoses is to try to determine, if you can, if the identification of a biological cause. People can present with Tourette syndrome just with these tic issues, or they can, and then eventually have some other neuropsychiatric problems down the line, or they can present with a complex array of involuntary movements and behavioral and psychiatric issues. And then some of the acquired forms, which we'll talk about, that may have an infectious or inflammatory cause, in those cases they may present solely with a neuropsychiatric disorder and then later develop motor problems or movement problems. So motor tics in general, if you will, are sudden, rapid, recurrent, and non-rhythmic movements or sounds, whether they be motor or vocal. They can be somewhat stereotyped. In other words, you can somewhat predict where they're going to occur. They could be classified as simple, involving just one group of muscles, for example, and but it should be very rapid, and some issues like that are blinking and shrugging and head jerking and throat clearing, grunting, and other sounds and noises, again, depending if it's a motor or vocal tic. Or they could be a little bit more slow, or what's called dystonic or tonic, such as a slow shoulder rotation, or blepharospasm is with the closing of the eyes. Or they could be more complex and involve different or several muscle groups that can be coordinated, and that can lead to movements such as bending and gyrating. And also things like echolalia is really, even though you're repeating what somebody's saying, that seems to be an involuntary movement involving various muscles. Palilalia, which is mimicking or echoing, if you will, somebody's movement. And coprolalia, as we discussed before. And again, these motor and vocal tics have, not in all cases, but in most cases, a premonitory sensation that you have some sort of feelings. Sometimes you can't even describe that feeling, that you're going to have one of these tics. And that premonitory sensation is useful in some of the treatment interventions, such as behavioral interventions with habit reversal, to try to recognize that, and then sometimes, in some cases, you can train yourself to suppress some of the tics for a time, but these are, again, involuntary and eventually sometimes will emerge. Now, the other hallmark of Tourette syndrome, and plays into our talk tonight for medication management, and sometimes is the primary issue, is really the associated neurological and neuropsychiatric disorders. Up to 90% of individuals with Tourette syndrome will have a neuropsychiatric concomitant. The most common are forms of attention and vigilance, which would fall under the rubric and label of attention deficit hyperactivity disorder, or ADHD. And the other major area is feelings of obsessive and compulsiveness, and falling under the DSM-4 diagnosis of obsessive compulsive disorder. Both from these disorders, as well as sometimes individually and separately, there can be anxiety, depression, personality disorders, learning disabilities as a standalone issue, or sometimes as a concomitant or result of the ADHD. Executive dysfunction, which is the brain's ability to sort of keep things organized like an executive of the company would do, and keep you on target and help you problem solve and keep all your brain functions organized. And of course, executive dysfunction can look like attentional problems as well as other issues, disorganization, etc. And impulse control disorder, which then leads into problems with anger management and sort of rage events. Another big problem in people with Tourette syndrome are sleep issues and sleep disorders, and that can be very important in terms of your daytime functioning. Sleep disorders could also mimic some of the neuropsychiatric disorders. In other words, somebody who does not have a sufficient and good night of sleep on a regular basis over periods of time will become inattentive and distractible during the day, or if they have something like obstructive sleep apnea, where they're getting insufficient oxygenation overnight, that could also cause daytime issues that can get labeled or mislabeled, if you will, as ADHD. Other neurological events that can sometimes be misdiagnosed as Tourette syndrome or a tic. I mean, there are certain seizures. Now, not all seizures are full-blown convulsions. Some could be just focal motor movements, and sometimes that could look like a tic, because it could also be very stereotyped in one spot. And a seizure is from an electrical discharge of the brain, and the treatment of that would be much different than you would for tics. There are other forms of movement disorders that have different causes and etiologies as well, such as I mentioned here, chorea, which is an involuntary movement that usually occurs when you try to do something, or if you will, an action. Dystonia and spasms, which are slower writhing movements, which can sometimes look or mimic a dystonic tic. And benign motor stereotypies, which often occurs in younger children and infants, where they could have recurrent movements that could be labeled as a tic, but are just a transient problem of development and tend to subside with time. Conversion disorders, which are neuropsychiatric problems where people will have various movements and other symptoms and signs that could look like Tourette syndrome but are not from Tourette syndrome, but more from deep-seated psychopathology. Allergies, of course, can cause recurrent sniffing and movements and other problems. And of course, if you control and target the allergies, your tics should subside. And I mentioned there's sleep phenomena, sleep disorders that could lead to problems with daytime, but there are also sleep phenomena, as most of us know. As we fall asleep, we could have little jerks, but during sleep, we should not be having tics. So if there are various movements during sleep that somebody is concerned might be tics or Tourette's, likely it's some other movement problem and not necessarily a tic, because if somebody truly is asleep, they should not be having tics. So as they fall asleep, they could have a few little jerks here and there. So the treatment for Tourette syndrome, tonight obviously the focus is going to be solely on the medications, but just to list here, the first step is really education and demystification of the disorder, both to help the patient, the family, as well as peers of the patient, because that could be a big problem, obviously, with social acceptance and social stigmatization. Health optimization, I think, is always important, making sure someone has adequate sleep, because sleep deprivation could worsen daytime tics and other psychopathology, neuropsychiatric disorders associated with Tourette. Reducing stress, as stress and anxiety can increase tic production. Good healthy diet and sufficient exercise can help to reduce the symptoms of Tourette syndrome. I showed you some sort of mimickers, and if there was a mimicker identified like an allergy, I mean, the treatment should focus on treating the allergy before trying to treat the symptoms of Tourette. Behavioral interventions have shown to be very effective, and in many cases should be really a first line prior to medication. The most comprehensive approach is the CBIT, which consists of cognitive behavioral component as well as habit reversal training. And for those with obsessive-compulsive problems, exposure response therapy can sometimes be very useful. We'll talk about the pharmacological therapies. And more recently, there's been some very strong interest in brain stimulation. This could be somewhat more invasive, if you will, with the deep brain stimulation where there's an implantable device within the brain, but now there's some interest in providing brain stimulation external to the head, transcranial magnetic stimulation, which is a little device that goes on the outside of the head and can provide a magnetic field in a very localized area. And that magnetic field will then generate a current within the brain, and sometimes that current can reduce various neurological symptoms. And one thing that has been looked at and been reported in rare instance at this point, but still may be promising to help with tic and other movements and other movement disorders. And in terms of direct current stimulation, which is a device that goes also on the outside of the head that provides a current across the whole head rather than just in a localized area, a very low current, very small current at about what a 9-volt battery can provide. There's been some anecdotal reports of its use in reducing tics. A lot more research needs to be done in the area of brain stimulation as it relates to Tourette syndrome and tics, but at least it's showing some promise. Older therapies, as I mentioned, where people went in neurosurgically and tried to disrupt various brain networks, basically through cutting various parts of the brain, had variable results, not well studied, and not something that would generally be recommended, especially with the promise of deep brain stimulation. So the topic of tonight's talk is medications. So let's get some general background on, why should we use medications for Tourette or for any disorder. But in Tourette's, I think the issue, and tics, again, this is a neurobiological syndrome. It does have response to behavioral interventions, and again, as I mentioned, often that should be considered first line prior to delving right into medications. But even when behavioral interventions are effective, they're not always fully effective, so there still needs to be some complement to them. And in some situations, behavioral interventions are not going to be effective at all. But when it comes to a decision for medication in something like Tourette, one has to understand if you're either going to target the tics or the movements, or do you want to target some of the associated problems, particularly the neuropsychiatric problems such as ADHD and obsessive-compulsive behaviors. But do these problems, the tics and or the neuropsychiatric symptoms, do they impair someone's function? Again, do non-pharmacological therapies or non-medication therapies, have they been ineffective? Are the tics in particular causing pain, or are the neuropsychiatric issues, if you will, causing psychic pain? And are the tics and/or neuropsychiatric problems causing issues in terms of social development or interaction, stigmatization to the point where a child, or an adult for that matter, is not able to function well in a social environment? Now, medications can sometimes reverse issues, whether they be tics and/or the comorbidities. Again, comorbidity is a word that says it basically means an associated problem, and that would be the ADHD and obsessive-compulsive disorders, for example. And when that happens, that can facilitate other types of therapeutic interventions. It could help for a child, for example, in school. If for an adult, it might help them in the workplace, and so you can maximize an individual's cognitive and/or functional potential and overall improve quality of life in many instances. But in the case of Tourette syndrome and tics, for the most part, medication treatments are treatments. They're not necessarily curative. They can suppress tics. They can suppress the symptoms of ADHD and obsessive-compulsive disorder, but not necessarily eliminate those processes. So then there's an issue of how long to treat and with what, and what other therapies might be useful as well. So medications, again, are adjunctive to other therapies, whether they be behavioral or other interventions. Now, to think about medications, in Tourette syndrome, a lot of it has to do with changing neurochemistry or chemistry within the brain. What we see here is a axon. All brain cells, or the so-called main brain cell, I should say, the neuron, or the thinking part of the brain, they all have only one axon, but what they do have is a lot of what are called dendrites, that these little branches of branches of a tree. So this would be a neuron over here. It would have just one axon coming out of it, and but many, many different inputs, if you will. So it's one exit and one input. These axons have these little, this would be the axon here, this would be a little myelin, or sort of the insulation of a nerve, such as the insulation on a wire. As you know, like an electrical wire will not function very well without insulation, and likewise a nerve doesn't function very well without its myelin. And certain diseases that reduce myelin affect brain function, such as multiple sclerosis. But you have this axon coming in. The axon has little chemical packets within the end of it, and through various reasons, usually through a electrical signal that's transmitted down this axon, it'll get to the end, and the packet will release its chemical, and there's a gap, and it actually travels across that gap, and then on the other side, there's all these little receptors that are specific for whatever chemical is being released. Once it attaches to that receptor, it'll then stimulate that dendrite to send an electrical signal. And of course, there's various electrical signals coming in from various locations. And it's somewhat analogous to a computer, somewhat more, maybe more elaborate than a computer, but analogous in the sense that a computer has what's called the binary system, or a 0-1 response. Either the network gets stimulated or not. And the neurons, too, take a cumulative, all these sort of pluses and minuses, a stimulation or an inhibition, and it adds it all up. And whether it tilts towards a stimulation or an inhibition will decide whether the neuron fires, if you will, and sends a signal down its axon to whatever axon it's attached to. So it's very complex because, of course, these axons impinge upon a neuron, and each neuron is getting multiple inputs. So it forms this very, very complex network of interactive neurons, or circuits, if you will, within the brain, very complex circuits. Again, somewhat analogous maybe to computer circuits. So you have the presynaptic axon and the postsynaptic dendrite. So you have the release of the chemical that travels across and then attaches to a receptor. These little chemical packets are called neurotransmitters, and that's listed here, and they come in different forms based upon their chemistry. Some of the ones that we like to talk about in tics are the dopamine and norepinephrine and serotonin. So the monoamines and the histamine, for that matter, are very, very important. But these others can have influence as well. And it does influence the type of medications that have been developed for tic management, as well as for some of the neuropsychiatric complications. So I just like to show this. I mean, if you take some of these chemical messengers like norepinephrine and dopamine, and they're quite beautiful structures when you crystallize them, and that's what they look like when they become crystallized. So when we use medications that affect neurotransmitters, I mean, how does this work? I mean, what the drugs do is they try to change the neurotransmitter balance. They try to change the, let's say, enhancing the availability of the different chemical messengers or neurotransmitters by inhibiting their recycling. So when one of these neurotransmitters gets released and goes to a receptor, once it's used, it sort of sits there and then gets taken up in a sort of recycling program and used again. If you inhibit that process, then it'll be more available to stimulate the receptor. Or you could try to stimulate the release of these little chemical packets in a more efficient manner. So again, you're going to enhance availability of the neurotransmitter that you're trying to target. The other thing you could do is you could create a drug that looks like the neurotransmitter, like dopamine or norepinephrine, and then it will then attach to the receptor, because the receptor won't be able to differentiate something that you're giving as a drug versus something that's native to the brain. Or in some situations, you might want to decrease availability, because sometimes these excesses of these neurotransmitters are not good. And that's particularly true in tics, where sometimes in some situations there's too much dopamine around and you want to try to block the action of dopamine. So you'll block the receptor. You'll create a drug that sort of sits in that receptor and blocks dopamine from being used. Or you might want to use some of these newer agents that will deplete the neuron of, let's say, for example, dopamine, so that there's not enough of it around to work. So that's one way that drugs can work. The other way they could work is try to work on the whole circuit, if you will, by decreasing the excitability of a nerve, or neuron, if you will. That can be done by some of the mechanisms that we just said. But there are also ways to modulate that by working on different what are called channels that are stimulated by some of these salts or electrolyte salts that you might be familiar with, like sodium and chloride. And of course, sodium and chloride together form sodium chloride, which is a typical table salt. Calcium and potassium, these are important ions or important salts that work in modulating the activity of brain cells. There are different neurotransmitters that tend to excite neurons and make them more active, so you could try to reduce them in some situations that might be preferable. Or if you want to try to decrease excitement of a nerve cell, you might want to enhance the availability of different chemicals, neurotransmitters that inhibit their function. So there's different ways that drugs could work, different sort of actions and ways to attack the problem. The other thing about medications that's interesting and very exciting is, can they protect the brain as well? I mean, can you give medications that could alter the disease process? So can you give medications, for example, for tics that might reduce future tics or the potential for future tics? We're not quite there yet, but there are some drugs that show some promise in animals that might provide some neuroprotection over the long term. Now, when using medications, you have to take a very rational approach. There should be some baseline testing and evaluation. Again, as you'll see in a moment, I like to say that these disorders like Tourette Syndrome are not medication deficiency syndromes. They're not a result of a lack of medication. Medications can be very useful when the diagnosis is made properly and under certain circumstances. But there shouldn't be a knee-jerk response just to provide a medication just because there are medications available. When using the medication, you have to start low and go slow is one of the mantras that we always use. You want to try to target the lowest effective dose. You don't just want to give a large dose starting right off the bat, because that usually increases your chance of having side effects. But if you take your time, raise up a dose in a gradual fashion, you tend to reduce the chance of side effects. When you use a medication, and let's say somebody is already on a medication, in some cases you might want to add the medication to that medication and then reduce the other medications. So you might want to bring it up to a starting dose and then reduce the other medications. You might want to do both simultaneously. It really depends on the clinical situation. Rational dosing, I mentioned the minimum effective dose, but rational dosing is important too, because again, if there's a tendency amongst a lot of medical practitioners to continue to push medications. Now, it is true that in many cases you can push medications as tolerated, but usually with most medications, as you get to higher and higher doses, side effect issues will increase as well. Sometimes you just have to say at certain dosages, if you're not getting a good response, that you might want to consider another approach, whether it be a different medication or a non-medication approach. Not everything is amenable to medication or might not be amenable to the medication that you choose. But I think you have to be somewhat rational in your dosing and try to target more lower doses or mid-range doses and try to avoid, when possible, higher dosing regimens. Now, there are many medications where the effectiveness of them can take some time. You might get a blood level, if you will, of the medication, but the pharmacokinetics are different than the pharmacodynamics. What I mean by that is that the effectiveness of the medication on the brain could lag behind what you could actually measure in the blood. And this is particularly true for anti-epileptic drugs, drugs that are called selective norepinephrine reuptake inhibitors, or SSRI, selective serotonin reuptake inhibitors. SSRIs are often used for depression and anxiety, such as Prozac is a common one. And they can sometimes take weeks, maybe up to even 6 weeks in many cases, to see a benefit, and that's after you reach a starting dose. So you have to take that into consideration. If there's a partial response to a medication, you need to allow for a longer duration of observation sometimes. So again, patience is very important with certain medications. There's also consideration of compliance and side effects. So if somebody doesn't take a medication, it's not going to work. So when somebody is coming for an evaluation and complaining that the medication is not working, I mean, one of the first issues is, are they, on the one hand, being compliant with the regimen? Particularly, this is very applicable with children. I mean, they might be fighting medications, or there might be missing medications, and adults too. This might be an issue where they might be missing their dosage. So in some situations, blood levels can be useful in those situations to try to determine compliance, but also people might be taking their medication as prescribed, and it's just not getting into the bloodstream. And that's where levels can help as well, to try to determine if the absorption is there. And one of the big issues is always, obviously, to monitor for side effects. One of the definitions of a drug is something that has side effects. So all drugs have side effects. They don't always occur in all individuals. There's the potential, I should say, for side effects. Every medication, all the way down to aspirin, has a long list of potential side effects. And fortunately, with most drugs, the side effect profile is favorable. But with some, it can be a little bit more problematic, and sometimes the side effects will outweigh the benefits of the drug. So, but you need to monitor for that. Some side effects people are aware of, but some side effects they're not. Sometimes it only can be measured from a laboratory test or something found on examination. The other issue is, if somebody's not responding to a medication, is to go back and re-examine your initial diagnosis and make sure that, on the one hand, you have the proper diagnosis, and on the second part of it is that maybe there's some other interfering diagnosis that you missed. And also try to choose, if you will, proper therapeutic targets. So, for example, in Tourette syndrome, do you want to target the tics, or do you want to target some of the neuropsychiatric problems? The other issue is to evaluate for any triggers. Particularly, this is true for tics, and might, in general, be very true for individuals with neurodevelopmental disabilities. Pain might be causing a lot of their problems. With neurodevelopmental disabilities or intellectual disabilities, they may not be able to describe the pain, and the only manifestation may be a worsening of their underlying behaviors and or their movement problems. Allergies, we mentioned before, and of course other medical conditions could be a trigger for the symptoms and signs of Tourette syndrome. Maximize your non-pharmacological interventions. The other problem is really using objective and quantitative outcome measures. Let's take ADHD, for example. In children, ADHD is often diagnosed by subjective questionnaires that are filled out by either parents, teachers, or other adult observers. In that situation, if you're treating based upon the results of the questionnaire, who are you really treating? You're treating really the observer rather than the patient themselves. There are ways to objectively measure a child's ability to pay attention, their level of impulsivity through neuropsychological measures, some computerized assessments as well. And that then really is a true measure of what the child can do or perform, and that's really what you want to target. Subjective questionnaires can help in certain situations as well, but again, you have to keep in mind that there could be a certain bias to the person who is filling out the form, and again, you want to measure what the child or individual can actually do. So you need some objective and quantitative outcome measures. In general, you want to try to avoid polypharmacy, that is the use of more than one drug. It's always better to use one drug. I mean, that will minimize your side effects, but in many situations, it's unavoidable. To really achieve success, you might need to use more than one drug, but you need to use them rationally and make sure that they're complementary drugs and that they don't interact with each other. And the other big issue is to review your medication regimen once in a while. Many individuals that I see coming to me, have maybe as teenagers or adults, they've been treated with medications for 5 years, 10 years, and no one has taken the time to say, is this medication still necessary? And they just continue on the medication. So at some point in time, you have to say, let's reverse this medication and let's reassess the situation and see if this medication is still necessary, if medication is still necessary at all, and whether this medication is the right one for that person. And in select situations, you might want to provide what are called drug holidays, or taking the medication away and giving somebody a break, if you will, from the medication, as long as they're still remain very functional in life without the medication. And utilize people that are experienced with the medications that they are prescribing. So we mentioned the objective assessment outcome measures. Again, you need to, this is a brain disorder, so you need to look at the brain. I mentioned that these are not medication deficiency syndromes, particularly when it comes to medications for ADHD, like psychostimulant medications, as you heard of Ritalin, Adderall, and some similar medications. These are performance-enhancing drugs. So they will help anyone do better, if you will, academically, or focus on a test or some other need to focus very intently. For individuals with properly diagnosed ADHD, these medications can be very, very useful in select situations. But the response to a stimulant medication doesn't make the diagnosis. There's other ways objectively to make the diagnosis of ADHD, because again, anyone will respond. And you may have seen some things in the press in the last month or so where there's been concerns of overuse of stimulant medications for enhancing neurological performance and not necessarily for treating disorders. And the analogy here, of course, is with steroids in sports. So you could take steroids in sports for sports performance and do better. There are side effects that often come along with that. But it's not that the steroids are treating a disorder, they're just enhancing performance. With medications, you want to make sure that we're not blunting creativity of an individual. What we're trying to do is enhance function and productivity. So then the side effect issues come in. So concerned about medications or side effects, short-term and long-term. In general, there's little data in children, and most medications that are used have been studied in adults and utilized in an off-label. I mentioned there's only 2 drugs approved by the FDA for tics, and yet there's other drugs that are used for tics. And then likewise for medications used in children for neuropsychiatric disorders, very few of them have been approved for that age group. And in general, we're using them based upon publications, anecdotal experience, and adult experience. And even in adults, there's many medications that haven't been specifically studied for tics and Tourette syndrome. There's a fear of medications, some of which are used for Tourette syndrome, that you might become addicted or dependent to them. That's not always the case if they're used properly. I should say is rarely the case if it's used properly. It's just when they're used recreationally, such as some of the medications used for ADHD, that they could become a little bit more dependent for them. There tends to be an aura for natural approaches, and we'll talk about that at the end. And there's always a concern that tends to not be a drug that could cure things. Everybody wants a pill to reverse everything, but that's not always the case, but there could be treatments. Now, some of the problems I mentioned medications is the issues of side effects. These are some of the, if you will, usual suspects or usual side effects that can occur, and these are specific for different medication groups, but just as a whole, We worry about things like metabolic changes, particularly weight gain and weight loss, inducing movement disorders. Now we're using medications to treat a movement problem like tics, but we could actually induce movement disorders. Problems with other toxicities to organs such as the liver, spleen, cardiac issues, effects on the heart, effects on the bone marrow, the blood-producing organ. Sometimes we'll use medications for behavior, but almost every medication that you could use to help a behavior can also cause a reverse response or an atypical response and actually cause worsening behaviors. Some of these medicines can induce a sort of hypomanic type of situation, and there's a growing concern with a lot of the medications that are used to control different behavioral disorders that they induce thoughts of doing harm to oneself, or what's called suicidality. Some medications can cause cognitive effects, usually through sedation. They can disrupt sleep. And the other problem in pediatrics is, again, we don't have a lot of data, so it's not always that children are little adults. You can't just, give us a lower dose, and sometimes children need a proportionally higher dose because they have faster metabolism. So we just need a lot more data in children, and often we don't have that, so that could be a problem as well. Before starting a medication, it's good to do some baseline practical testing to make sure there's not an underlying problem to begin with before you actually get into the actual treatment. That's always important to know. This includes a good clinical examination, sometimes some laboratory testing, electrocardiogram baseline to assess for any underlying pre-existing problem with the heart is, I think, very important. And there's this growing area of pharmacogenomic profiling. There's now 14 genes that have been identified that affect medications that are used for neuropsychiatric disorders, or what are called psychotropics. They can affect there are genes that can affect the drug metabolism, how it's eliminated from the body, how it's transported into the different cells, and how also different receptor issues. So there's going to be a very interesting approach to medications that's available now, and it's going to be a growing issue in the near future, where we're going to be able to genetically profile individuals and tell which medications from a genetic basis might work better than others. And that also might also tell which medications might cause more side effects in a certain individual based upon their genetic profile. So this is a very exciting area. And a lot of these pharmacogenomic tests can be done on saliva, so it doesn't even take a blood test. So getting into medications themselves, which medication to choose, you have to use something that hopefully has some evidence in Tourette syndrome or useful this in tics, different approaches from research, what are called clinical trials. You might also look in the medical literature for studies that have been published with the medication, and maybe looking backwards or retrospectively, looking in larger populations, or prospectively in what are called open label and/or controlled studies. But the main gold standard seems to be the double-blind placebo-controlled studies as listed on top. Someone might have, a healthcare provider might have clinical experience with certain medications for tics and Tourette's that they favor. There may be parental impressions. Again, that could be a little bit dangerous, getting too much information off the internet and from the media. That's often very unfiltered and hasn't been subjected to any scrutiny, so you have to be very careful about testimonials and things that you find on the internet, but sometimes that could be a source to try to educate yourself about medications. We try to choose medications, obviously, that have the lowest toxicity and the ones that have some evidence for their use. We want to use ones that are known to be useful or efficacious. If more than one drug is being used, you want to make sure that they're compatible. And then there's the issue of generic medication versus brand medication. Despite the publicity on generics, they are not necessarily the same as brand medications. The chemical formula is the same, or the basic chemical is the same, I should say. The basic drug is the same. But the formulation of the pill is different. That's what's proprietary to the brand. So that even though you might have the same basic chemical, it might not get into your bloodstream as efficiently, let's say, as the brand, which might have more evidence for and longer-term studies for it. And the other problem is that generics have, if you will, their own brands. I mean, there's different brands of generics, and pharmacies in New Jersey, for example, are not by law required to tell a patient if they switch the brand of generics. So we have people even on generics who have worsening of their symptoms, and then we go back and find out that the pharmacy changed their generic. The other issue is we do see worsening in certain types of behavioral disorders and neuropsychiatric disorders when switching from a brand to a generic. So there are some issues with the quality of how reliable certain generics are, but many generics are very reliable. One little trick I'll tell you is to look for generics that are made by companies that make the brand of that drug, because the generic company of the main parent company will use the same formulation as the brand. And that's a little secret that they don't tend to publicize very much. But if you get a generic from a company that's not owned by the company that makes the brand formulation, then it'll be a different formulation. The FDA has only approved 2 medications for Tourette and tics. That's pimozine or Orap and haloperidol or Haldol. These are older medications. They have some substantial side effect issues, but there are a lot of other medications that are now used. One thing is the FDA doesn't require in the United States a head-to-head study, so that most medications that are studied and come out with some evidence and data for them are usually compared to placebo. But they don't necessarily tell you which drug is better, because the FDA doesn't require head-to-head studies, so pharmaceutical companies tend to just do studies that compare medications to placebo, and placebos, as you might know, are sort of non-active substances like sugar pills, for example. The medications that are used to control tics, first we'll look at tics prior to neuropsychiatric symptoms and problems. The sort of first tier approach usually is the alpha-2 adrenergic agonists. Guanfacine and clonidine are the main medications in this category. They work at the level of the brain. They tend to activate inhibitory neurons and reduce what's called sympathetic outflow, and secondarily will tend to reduce tics in some individuals, but not all. These medications also are used to control blood pressure, particularly in people who have sort of a type A personality, as they tend to reduce this sort of adrenergic or sympathetic overflow, or if you will, sort of an over-adrenalized type person. But they have a very favorable side effect profile, so they're usually worthwhile to try before you go to the second tier, which are the dopamine and serotonin receptor blockers, or what are called antipsychotics or neuroleptics. They come in the older typical forms, and this little D2 and D1 are different types of dopamine receptors that they block. I mentioned haloperidol and pimozide, and then there's also fluphenazine and trifluoperazine. But again, side effect issues are very significant with the typical neuroleptics, and even the atypical neuroleptics have significant side effect issues. And these include medications like risperidone and other ones that are listed here, which we'll talk about. Other considerations for second or third tier after you fail on alpha-2 adrenergic agonists, certain seizure medicines or anti-epileptic drugs, levetiracetam or Keppra or topiramate, which is Topamax is the brand name, they have some evidence to reduce tics. The dopamine depleters, tetrabenazine is a newer medication, or Xenazine is the brand name. It shows some. It was approved for other types of movement disorders other than tics, and it works by depleting the dopamine. The benzodiazepines, or the classic one, is the Valium-like medicines, if you will. Clonazepam or Klonopin is most commonly used, but most of the benzodiazepams work the same way by enhancing inhibitory neurotransmitters, and they can be very good muscle relaxants and also tend to reduce anxiety, which secondarily can then reduce tics, and they might also have some direct effect on reducing tics. The problem is their long-term use it can be problematic. Some people use botulinum toxin or Botox, which, as you know, is used for wrinkles on the face. It paralyzes muscles, so it can be used for some types of tics that are very occurring in the same spot all the time, maybe such as an eye problem or a neck problem. And then there are some dopamine agonists. This is somewhat counterintuitive because higher dopamine tends to cause a problem with tics, and dopamine agonists are used for things like Parkinson, where there seems to be a low dopamine state. But in some situations, there's been some hypothesis for this, but it's not commonly used for tics. So the alpha-2 adrenergic agonists I mentioned, these are some of the brand names that you might see. Catapress, Bay is a long-acting catapress or a long-acting clonidine. And then the guanfacine, which is 10x, the short-acting, and Tuniv, the long-acting. They've been shown to be effective in ADHD, as well as tics that are mild to moderate. Some of the problems mostly are getting tired on the medication. That can be sometimes transient and reversible. I mentioned they sometimes were initially developed for lowering blood pressure, so they can cause some low blood pressure that has to be monitored carefully. And I mentioned the extended release forms of Capley and Tuniv, which makes it a little bit more palatable. The typical neuroleptics, I mentioned Haldol and Orap are approved, Prolix and Stelazine or some other ones. These are brand names. They are for more moderate to severe tics, but again, should be considered more second line because they have a lot of potential side effects, weight gain, induction of a sort of adult diabetic condition. They can induce movement problems. The most fearful one is tardive dyskinesia. They can also induce a Parkinsonian-like state, look like Parkinson's disease, if you will. They can affect your cognition. There's cardiac issues, particularly with ORAP. And they could increase hormones like prolactin, and that could lead to unwanted breast development in a male, for example. So a lot of issues. They need to be monitored carefully, but they can be very effective, especially when used rationally. The atypical neuroleptics, for the most part, have a more favorable side effect profile compared to the typical or older neuroleptics, and they're listed here. The brand names Abilify, Risperdal, Geodon, Zyprexa, Seroquel, Clozaril, and Invega. Again, moderate to severe tics, usually considered more of a second line. But they still have the same side effects in general, but it tends to occur less frequently. Some of the seizure medicines I mentioned, Topmax and Keppra. It's not known really how they work for tics, but they seem to work for tics, and they can be considered as a second or third line if other approaches are failing. Xenazine, again, a much newer medication, not approved for specifically for tics or Tourette's, not well studied, but there have been some reports of usefulness in tics, moderate to severe tics, if you will. Side effects are mostly sedation and tiredness, and also the induction of other movement problems. I mentioned the Botox injections is very, very localized, and it has side effects as well, and should not be taken lightly. And then there's medications targeting the associated disorders, the ADHD and obsessive compulsive and other neuropsychiatric symptoms. This is mostly the stimulant category, non-stimulant category as well, the SNRIs. Alpha-2 adrenergic agonists are considered non-stimulants, the benzodiazepines, and the SSRIs. Atomoxetine or Strattera is a non-stimulant approved for ADHD, and in studies has shown not to exacerbate tics in those who have ADHD and tics. So it can be used quite safely in that situation and can be very useful for the attentional problems in ADHD. Some of the side effects are listed there, but they occur relatively infrequently. Benzodiazepines can be used for anxiety. Again, long-term use is not necessarily desirable, but they also can help tics through muscle relaxation. They can reduce tics by reducing anxiety. So they can be useful for short-term therapies, and in some cases can be used long-term, at least certain types of them like Transine and Klonopin, for that matter as well. The psychostimulant drugs are well known for ADHD, and again, they've been very heavily publicized lately. And here are some of the brand names that I mentioned here. The slash for SR/XR means there's the focal immediate release, and then there's focal XR, which is the long-acting or extended release. ER is for extended release. XR is extended release, and SR is sustained release, and CD is also a sustained release. And then, so there's the methylphenidate products or stimulants and the mixed amphetamine salts like Adderall, Aloxar, and Vyvanse. They tend to enhance the availability of dopamine and norepinephrine, and therefore there was some concern that they could exacerbate tics. There's been some studies to show that that's not necessarily the case, so they can be used in people who have tics and Tourette syndrome. But I think they still have to be used somewhat carefully because I think my clinical experience has shown that still can exacerbate, but they also exacerbate anxiety. So maybe the exacerbation of tics might be the result of making anxiety worse in some situations. But the side effects, as you can see, are decreased appetite is a main issue, affecting the ability to fall asleep, making people more irritable, And again, we talked about the concept of using them as performance-enhancing drugs rather as therapeutic products. The SSRIs are listed here: Prozac, Zoloft, Celexa, Lexapro, Luvox, and Paxil. Many have been around for a long time, like Prozac. They're very useful for anxiety, depression, reducing obsessive-compulsive symptoms. But they have some adverse effects that could, again, have the reverse type of behavioral effect that you desire, making people more activated. They can affect sleep in some cases. We talked about the issue of suicidality. And they have interactions with other drugs. And again, that pharmacogenomic profile can sometimes clue you in as to whether or not you're going to have that risk of that drug interaction. So that's where that can become very useful. And just to finish up, I mean, there are issues of the aura of natural therapies. One thing about natural approaches is, if you will, that, you know, sometimes a very general term. I mean, many drugs are natural. I mean, they've been derived from plant substances. And a lot of that's what's out there that's considered natural is not under the scrutiny of the Food and Drug Administration. So we don't necessarily know, you know, what toxins might be contained in there. And many plants and other substances are very toxic to begin with. Many recreational drugs are from plant substances, such as heroin and poppy plants. Food supplements, you know, sometimes can be useful in overall health. Nothing specific for tics at this point in time. But in general, if you want to embark upon, if you will, an integrative alternative or complementary approach, understand what the safety is of the substance, because, again, these aren't necessarily safe substances. Understand what the evidence is for the use in the disorder that you're looking at. Is there any scientific sense to it, you know, either hypothetically or theoretically? And what is the cost? If it's something that has been out there and is somewhat useful, that's been subjected to market forces, and usually there'll be some reasonable cost. If it's very expensive, it might be an entrepreneur that's trying to take advantage of a market, if you will. And try to be careful with fad therapies, because these come and go all the time. They can sometimes be dangerous and harmful, and they can sometimes take you away from rational approaches. So in conclusion, don't use medications to make a diagnosis. Be rational when you utilize medications. Use them when they're indicated. They should be part of a total treatment package with other sort of behavioral and other interventions. Medications are useful when they're indicated, when they're tolerated, when the risks outweigh, I'm sorry, when the benefits outweigh the risks. And utilize some rational approaches to baseline testing and ongoing monitoring when you're on a medication. Reevaluate periodically your medications, sometimes by doing a reversal, if you will, taking it away and seeing if it's still necessary. And in general, whether it be medication treatment or non-medication treatments, everything needs to be personalized and individualized, and maybe even in terms of your genetic profile for that matter, because medications don't work for everyone, or a specific medication may not work for a specific individual. But unfortunately, you know, with Tourette syndrome and tics, since it's been known in 1500s and the 1400s and the 1500s, highly effective therapies are still lacking for many patients, and many individuals still suffer with tics and Tourette syndrome and don't respond to some of the available therapies. So there's still a need to research further and come up with more effective approaches, whether they be medication or non-medication. So thank you very much, and we'll take questions now.
All right, Dr. Mintz, thank you. That was a lot of great information. I'm going to jump right away into questions. We've had a number of them posted, and we'll get to as many as we can during this Q&A. You just talked a little bit about alternative medications. I didn't hear you specifically mention this one that was a question on, so I'm going to approach you on valerian. And can you talk about that? Do you know anything about it?
I'm not that familiar with valerian. I think it's from a root, if I'm not mistaken, valerian root. I really don't know its evidence in Tourette syndrome or tics, or in neuropsychiatric disorders. I remember reading some anecdotal information, but I can't really say that I could recommend it without understanding it a little bit further.
Mm-hmm. Okay, good, thank you. Are you aware of, or is there any evidence that you know of about Klonopin causing seizures in some instances?
Right. So, as people may know, I mean, Klonopin, which is a Valium-like medication, as I mentioned, can be used for tics and Tourette's. It also is actually used as a treatment for seizures. Valium medications are very good for treatment of seizures. It would be unusual for Klonopin to induce a seizure, but every medication that's used for seizures has that small risk. But usually, when you actually study it, when it gets reported as a side effect, and then you study it, you can't necessarily develop a cause and effect relationship. So I think that would be very, very unusual for Klonopin, not clonidine. I think they're asking about Klonopin, which is clonazepam.
Yes,
Klonopin is the brand
yes.
is the brand name of clonazepam. Highly unusual for that to induce a seizure, but not impossible. Again, every seizure medicine that I've used can sometimes make seizures worse in individuals who are susceptible to seizures. Now, and sometimes that could also be the phenomena of withdrawal. So somebody who's getting Klonopin to treat a seizure, or in somebody who may not have had a seizure before, if it stopped abruptly, cold turkey, if you will, you can sometimes get withdrawal and induce a seizure. So that can happen as well. And that might be a situation that the person's referring to.
There wasn't any elaboration beyond that.
Sure.
Can you talk a little bit about what kind of research goes into medications for long-term side effects? Like, how do they study that?
So it's an interesting question. I had one slide on that. We didn't have time to go in great depth into that, but in the United States, to get a medication to the public is a very, very difficult process, and also a very, very expensive process. And not to necessarily defend the pharmaceutical companies, but they do have to make hundreds of millions of dollars of investment to get a drug to market, and in many cases they fail. So they're taking a risk, and often they're successful, and they can make tremendous profits as well. But it is a process in this country, and the process is based upon our sort of free market system. The government has, for the most part, largely gotten out of drug development. There's some funding available for research for drugs, but it's mostly dependent right now on pharmaceutical companies. And there's four basic phases. There's first of all, there's sort of drug discovery. Sometimes drugs will be discovered maybe in the jungles, and sometimes it might be created in the lab, a designer drug, if you will, based upon certain chemical characteristics. And then there's sort of there's some testing in animals to see if there's any efficacy or potential for that drug to go further. Then in human trials, it starts with phase 1, which is just giving a medication to see how much you have to give, how much gets into the bloodstream, and also if it's safe. And then phase 2, which is likewise a safety study, but looking more at the activity of the drug in different ways. Phase 3 is does the drug actually work for the disorder that you're looking at? So then you target something like Tourette or ADHD or tic. And then after phase 3, which is a long process, I mean that takes years and hundreds, sometimes thousands of patients to get to that phase. The FDA will look at the data and say, this drug is something that is approved, and then if it's approved, it could go to market. And then there's phase 4. Now, phase 4 is taking the drug. Maybe it's approved for seizures, but then somebody wants to try to use it for headaches and migraine. And that's happened many times. And then you'll do additional studies. Even though the medication's available in the pharmacy, you'll study it for some other indication. Now, after it's on the market, there's ongoing surveillance, and anytime there's a side effect or some other problem, it's supposed to get reported to a generalized database, and then the FDA will continue to monitor that drug. And as you know, I mean, many drugs come to market with good, relatively good safety profiles from the clinical trials, the 3 phases of the clinical trials, but it's not until they're widely used, some people say you need to hit 100,000 patients, until new side effects are uncovered. Celebrex, which was a rheumatic drug, was found to have cardiac issues after it was released on the market and was pulled from the market. So sometimes you'll see that drugs are released and then they're pulled. And
so the long term, it has to be out there and in use.
Yeah, it has to be out there.
There's no
way you could do a study on 100,000 patients for many, many years. I mean, it's just not feasible. It can never be done. So you have to get things out into the population and study them, and unfortunately that sometimes, some people will have adverse events that are unexpected. And
thank you.
You just have to there's ongoing monitoring for side effects.
Okay. We've had a number of questions about treatments for TS and comorbids, OCD and ADHD. But this question has more to do with weaning off meds. So you've had a kid, presumably, that's on meds. Is it assumed that they take these meds forever? Like, what is the idea that, how would you test, I guess, to decide when you might reduce meds or take a child off meds? Or
so it has to be individualized, but like I mentioned, that's a very, very important concept that, you don't necessarily just put somebody on a medication and forget about it and just keep renewing the prescription. You have to have ongoing surveillance, like I mentioned, some objective measures of outcome, how the performance and function. And if somebody's, on the one hand, well controlled, whether it be tics or whether they're well controlled with their OCD or ADHD, and doing well, it may be the result of the medication, and you give them some time to achieve success. But at some point, you have to make a decision, is this medication still necessary? So you might want to reverse it. You might want to start to wean it slowly and monitor performance while you're weaning it. On the other hand, what I often see is that people on multiple medications with a lot of toxicity and side effects, and they're still having a lot of tics and a lot of problems with their ADHD and OCD. I mean, so the question there arises is, well, why are they getting the medication at all if it's not effective? And that happens quite frequently. And what happens is somebody will add a medication or increase a dose without taking away the medication that hasn't been effective. So they'll add or they'll add a medication, things get better, but they never bother to think, well, maybe that first medication or the other two medications are not necessary and could be reduced. And then again, side effect issues increase.
So it's playing with the combination that has to be done very carefully then.
Or they might be on a single drug, and you just want to wean it down. But again, the key really is how you monitor and how you measure. And I think subjectiveness is good. I mean, to some level. I mean, asking people how they're doing and how you do or how you are doing, but you have to measure it. I mean, there can be ways to measure attention and focus through, I mentioned, some computerized measures called continuous performance tests or neuropsychological tests that can look at both that. They can also look at emotional factors. There are various questionnaire forms, again, which can be rather subjective but can still provide some information. And just a clinical exam, and there's laboratory tests that need to be done. I mentioned that there's some laboratory hormones and other things that could increase with certain medications. And when that happens, it could be very silent. You may not know it right away, so you need to pick it up early. Heart changes, conduction problems. So again, careful monitoring, ongoing reevaluation. I think that's for just being vigilant over time.
You're right, absolutely. A question comes up. It was asked today, but it comes up other times from parents we talk to, that you've got a teen, and the question is whether or not the child should be put in some hospital setting for better management, and removing the teen from home into some kind of a residential facility. Could you talk about that a little bit? That's a pretty dramatic step for a family to take.
Yeah, a very dramatic step. I mean, there's a lot of factors that play into that. Is there underlying neurodevelopmental disability, intellectual disability? What are the behaviors? Is there dangerous behaviors in terms of aggressions or dangerous self-injurious behaviors or suicidality? So in certain situations, it may be necessary to protect the individual or the patient. In some situations, it might be to protect the family. It really depends on the situation. So in those situations, it can be useful. But again, it has to be individualized. When there's a situation, and again, the question was rather broad, but let's just focus on, let's say, dangerous behaviors, for example. In that situation, I think there needs to be, again, some analysis of what's going on. Too often, medications are used as the primary mode of treatment. And whenever there's a complaint of things that are worsening, there's just a tendency to increase the dose of the medication or add more medications or add a medication for every symptom. And that just leads sometimes to worsening the behaviors and worsening the symptoms and, of course, a lot of side effects, and it's very detrimental to everyone. So sometimes you just have to take a step back and analyze and see, well, why is this behavior worsening? what is the situation? You can do what's called a functional behavior analysis. You can look at the individual for medical problems. And again, let's say it's an individual with autism who has sort of Tourette-like syndrome and is non-communicative. I mean, maybe they have a dental abscess or a cavity or something causing them pain and everything's getting worse. And that's all that, and that could avoid a whole hospitalization and other problems. But if you have someone who's intellectually intact and developmentally appropriate, maybe they're going through significant emotional stress and can't handle their situation. So are they getting sufficient behavioral supports and other supports that might avoid a hospitalization or a facility placement? So again, it has to be very individualized, but I think the problem is always looking, number one, at other factors that may be causing the situation worse, analyzing them appropriately. And like I mentioned before, when things aren't going well, you have to sort of look at your diagnoses again.
Mm-hmm.
Is your initial diagnosis appropriate? Your neuropsychiatric diagnosis, for example. Are there other diagnoses that you're missing? And particularly in my hands is really looking at the biological causes. I mentioned that all these DSM-4 or neuropsychiatric or neurobehavioral diagnoses are diagnoses that are not dependent upon what causes them. So again, you really need to get to the basic cause.
Yeah, and that's a team effort then. I can see that between the parents and the individual patient and the doctor and trying to determine what's going to make the most sense.
And not just the doctor. I mean, physicians can be useful, but sometimes they can't be very useful, and it takes a further team. I depend heavily upon our behavioral therapists, our neuropsychologists, our nurses, even our music therapists and creative arts therapists that can do wonders with a lot of our patients. So it takes a healthcare team as well.
It takes a village. Okay.
Yeah.
We have time for one more, and this question, it has to do with self-medicating, and since we have so many young adults in our population among the TS community, would you discuss a little bit about self-medicating, which I think is often done by young adults who have some neurological issues?
So if we're talking about self-medicating, in other words, taking
alcohol, smoking pot,
alcohol,
yeah.
It's a red flag. It needs to be looked for. One of the biggest issues I mentioned was this concept of neurological enhancement with the sharing of stimulant drugs like Ritalin, Adderall on high schools and college campuses. People use their friends' medications to do better on a test, and then think they have then they think they have ADHD, and just because they did better on the medication, it's not the case. So it is a problem, but it's definitely a red flag, and it's something to look at. Again, in the situation, let's say, when behaviors are worsening, one might want to look at self-medication. But I think if you take someone who is identified as self-medicating, and get them in the proper therapeutic with proper therapeutic modalities, and try to provide them appropriate therapeutic interventions, which may or may not include medications, things can usually turn for the better. This way they get a little bit more self-esteem and self-confidence that they can control their disorder in other ways rather than just using illicit products.
Mm-hmm. All right, I think we're going to have to wrap it here. We've gone quite a bit over. Dr. Mintz, thank you very much. It's been a great presentation, and we much appreciate it.
Thank you.
Thank you for joining us on our webinar on medication management and for tics and Tourette syndrome. There is an exit survey which we need everyone attending to fill out. The discussion board is open now and available for the next 7 days on the NJCTS website for any additional questions that were not covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to our website. The next presentation, Tourette Syndrome in the Latino Community, presented by Dr. Richard Zakreski and Laura Zakreski, is scheduled for June 19th, 2013. This ends tonight's webinar. Thank you, Dr. Mintz, for your presentation, and thank you for everyone for attending.